Hello guys, welcome to MedIndian. Today we'll be studying about nephrotic syndrome. So nephrotic syndrome is a very important 10 marker, and by definition, nephrotic syndrome, it is a clinical syndrome which is characterized by four things, alright? That's proteinuria, hypoalbuminemia, generalized edema, and hyperlipidemia. Next thing, we need to see the causes. What are the causes? It can be the primary causes or secondary causes. Primary causes, we have minimal change disease, focal segmental glomerulosclerosis, membranous glomerulonephritis. So the most common cause is minimal change disease that is seen in mostly in children, and in adults we get mostly membranous glomerulonephritis. Okay, now in minimal change disease, there is very, as it's written, there are minimal or absent glomerular changes. But if you see through electron microscope, we can see there's diffuse loss of food processes of podocytes. In FSGS, we get what we can see is there's sclerosis of capillary tufts of glomeruli. It is seen in 1/3 cases, and membranous glomerulonephritis, as I said, it is mostly seen in adults. There's uniform diffuse thickening of capillary wall. Why there is a thickening is because there's dense deposits of electron along the capillary wall, uh, so it causes a thickening. Now coming to the secondary causes, first thing is infections like hepatitis B, HIV, malaria. Second thing is connective tissue disorders like SLE, rheumatoid arthritis. In neoplasm we get Hodgkin lymphoma, and in metabolic causes diabetes mellitus or amyloidosis. Coming to the pathophysiology, now whenever there's a glomerular damage, there's increased permeability to proteins. Now this leads to massive proteinuria, more than 3.5 grams per day. Now where there's massive proteinuria, we get serum albumin goes down, so we get hypoalbuminemia. Now when serum albumin goes below 3 gram per 100 ml, we get two things. One is decreased plasma oncotic pressure, and this increased synthesis. Now coming to decreased plasma oncotic pressure, when the plasma oncotic pressure decreases, we can directly get edema, or it causes decreased plasma volume, which instead causes decreased GFR, which triggers RAS. So there's increased aldosterone secretion and sodium water retention, leading to edema. And next thing we come here is there's increased synthesis of lipoproteins, but here there's increased synthesis but there's decreased catabolism, so that leads to hyperlipidemia. So now what happens is, when there's hyperlipidemia, these lipids go for filtration, but due to this, because there's a glomerular damage, there's leakage of these lipoproteins. Now these lipoproteins are reabsorbed by our renal tubular cells, and there they are shed along the degenerated cells. So in urine we get fat bodies, which indicates lipiduria. Right. So what are the investigations you do to find out nephrotic syndrome, to rule out nephrotic syndrome? First thing is obviously urine examination. In urine examination, we'll obviously get a proteinuria, and if you do microscopy, we get red cells or red cell casts. Next thing we read in the definition, there'll be hypoalbuminemia. So check for serum albumin. Serum albumin will be low because there was hyperlipidemia. So what will we check for? We'll check for serum cholesterol, which will be increased. Renal biopsy is not necessarily needed in all conditions, and then we'll do other like investigation depending on the suspected cause. Like if you suspect there's any infection, like we have read in the causes, secondary causes can be infection, neoplasms, etc. So we try to rule out the infection. So we can for HIV, hepatitis B, you can check for that. And if you suspect neoplasm like Hodgkin's, you can do a benzone protein test. So we'll get to know the cause. Now management, once we get to know the cause, we'll manage. First thing is you need to reduce proteinuria. How do we reduce proteinuria? We can use ACE inhibitors. They reduce proteinuria. They also reduce the rate of progression of renal failure by lowering intraglomerular pressure. Next thing, we need to control or reduce the complications. What are the complications due to nephrotic syndrome? Edema, hypercoagulability, hyperlipidemia. So first thing, to treat edema, we need to restrict diet. So there should be salt restriction in the diet. Next thing, medical management, which we can go for thiazide. While giving thiazide, You need to make sure there's controlled weight loss, that is less than 1 kg per day. If you go for an aggressive therapy, it will lead to acute renal failure. So you should always go for controlled weight management, right? If the patient is not responding for thiazide, we can also use furosemide 40 to 120 mg per day. But if there's a gut mucosal edema, this oral drugs will can't be absorbed, so there's malabsorption. So in that case, you can go for parenteral drugs. Next thing is hypercoagulability. There's due to loss of coagulatory factors, you get hypercoagulability. So for that, you can avoid prolonged bed rest, and or you can put the patient on long-term anticoagulant therapy so as to prevent thromboembolism. Next thing, hyperlipidemia causes hypercholesterolemia. So you need to advise the patient to modify his diet, not to take fatty foods or cholesterol containing foods, and medical management you can put the patient on HMG CoA reductase inhibitors. Right. Next thing, you need to treat the underlying cause. Now the most common cause, as I said, is minimal change disease, which is mostly in children. So initially we give corticosteroid therapy with prednisolone 60 mg per meter square daily for 4 to 6 weeks. Now, after that, it is followed by an alternate dose of prednisolone 35 mg per meter square for 4 additional weeks. If there is relapse, not necessary all patients respond to steroid, right? So if there's relapse, you can go for cyclophosphamide for 8 to 12 weeks with concomitant prednisolone. So prognosis is really good. So in cases of children, you go for 6 weeks therapy, 4 to 6 weeks therapy, and adults go for 12-week therapy. So that's it. Thank you. If you like this video, please like, share, and subscribe.